My name is Kojo Hamilton, as you know, and I have the privilege of following these esteemed speakers to talk to you about management of thoracolumbar spine trauma, pearls, and pitfalls. I will move rather rapidly through the course materials since this will be more of a refresher for a lot of people. Let's see. So the objectives will be a thoracolumbar fracture overview, review of the classification systems, non-operative treatment, operative treatment, and a few case examples. The first thing will be that is the most commonly injured portion of the spinal column, okay? 20-25% of all traumatic fractures in young adults, and about 5,000 of these out of 15,000 major thoracolumbar injuries that occur in the US will have neurological deficits. And to sum this up, I always ask this question, it seems like everybody's able to get it these days, that fractures within T1 to T10 are less common and they're associated with more horrific injuries, including pelvic lower limb fractures. This is a massive trauma situation. If you do have T1 to 10 thoracic spine fractures, that even includes sometimes even those who have what we call different spinal alignment, okay, or even different spinal morphology. People with AS, rheumatoid, ankylosing spondylitis, I'm always worried about they having T1 to 10 fractures, may hide long or large vessel injury. So why is the thoracolumbar spine injured? It's mostly moving from a kyphotic, immobile, stable spine to the lumbar spine, which is lordotic, mobile with large vertebral bodies. And also there's a lot of rotational and shear forces at that junction, okay? So things that we worry about is spinal stability. We've talked about alignment, talked about stability. We've talked about avoiding complications associated with access and also stabilization. But really, we're trying to, the spinal stability really involves the ability of the vertebral column to withstand any deformity and also prevent neurological damage, okay? And the thoracolumbar lumbar level, the anterior column provides 80% of the axial load bearing, while the posterior column resists torsion and shear about 80% of the time. Most of these injuries are caused by indirect trauma with combinations of flexion, axial loading, lateral compression, rotation, distraction, shear, and also extension injury forces. And also the loading rate is critical to the determinant of the type and severity of the injury, okay? So things that I always caution people is it may not look as bad as a radiographic description, or it may be worse than how it looks like when you examine the patient, when you're in surgery. So the x-rays don't really tell you how bad somebody is, okay? So if I look at this and I'm trying to communicate, things that come to my mind would be Charlottesville. They're going through some issues today, but back in say 2000, I had my own issues with Chris Shaffrey calling me at 2 a.m. with this fracture, and this was PGY 2, second week, trying to tell him what this was from an ATV accident, a older gentleman who should have known better and not put me in this situation, but here I was, 3 a.m., called my chief resident. He was doing a shunt downstairs. He said, oh, just call Chris Shaffrey because he was off the hook. He had an excuse not to call the attending directly. So here I was, called, and he says, hey, what's going on? I said, there's a big fracture, and the chief resident asked me to call you. The patient's not moving his legs very well. At 3 a.m., he had done a big T to the pelvis the day before, and all hell broke loose. So then I realized that, you need to be able to classify fractures, okay? There's no universally agreed upon classification, but if somebody's on the phone or you're in a conference and you put this image on, we should all have an idea as to how to describe this, what to do, and also to have some qualifiers to it, okay? So the ideal classification should be simple, include vast majority of injuries, reflect mechanism of injury, correspond to anatomic pathology, determine treatment options, determine prognosis, and the last one is avoid being yelled at and threatened to be expelled from the program. Okay, so you have to then understand that you also have a 3-column. So initially, I could have even skated away if I just known the 3-column theory of thoracolumbar fractures. This is the old tried and true where people learn all the other modes of classification, but then they revert to this when they start talking to their peers, right? And this really involves describing the anterior column, which is the anterior vertebral body, and the annulus, the middle column being the posterior vertebral body and the annulus, and then the posterior column being the third column, which include the pedicles, lamina facets, ligamentum flavum, intra and supraspinous. But then the academicians took over. We needed to do a little bit better than to just say this is a compression fracture because the ligament in the back is intact, the canal is intact, versus this is a stable burst fracture, there's some loss of height, canal occlusion, comminution, posterior column injury, neuro intact. I had barely gone through the first chapter of the neurosurgery handbook where they talk about ICU management, and this 47-year-old burst through the door. All I needed to do was know a little bit of this, and I would have been free. But unstable burst fracture, this is loss of body height, posterior column injury. There is some spinal cord injury, a nerve root injury involved, I suppose. And then it gets worse with flexion distraction injuries, chance fractures. Who does not know what a chance fracture is? Good. All right. And then a fracture dislocation, which is globally unstable. We're more involved in stabilizing the patient and packing the nerve roots if possible in this situation. So that was not good enough. People in 1994, they AO started their own classification based on a 10-year review of 1,400 cases. This was part of my assignment following that debacle of that night to sort of review all classification systems. And it was supposed to serve as a comprehensive classification system that could guide treatment. And it had sort of 3 major categories. Compression, those were A, B, type fractures were distraction injuries, and C type were rotation. And you could also get 3 different categories from these big categories. So at the end, you ended up with a 53 separate injury pattern. This was not something I could communicate properly in 2000, and this was when life was much easier. So in 2005, after people had decided that this didn't help because it didn't really communicate the neurological status of the patient, etc., the thoracolumbar injury severity score came about, which was much simpler. I tend to use this quite often. It's a simpler scale, 3-part description of injury morphology, integrity of the posterior ligamentous complex, neurological status. Okay, let's see. There we go. So it's a point system. Who has never heard of this before? Who uses this frequently? Who does not use this system at all? What system do you use to describe thoracolumbar fractures?
Basically stats.
You use a 3-column?
Yeah.
Okay. Where are you from? Wake Forest? Okay. That's doable too, but it's nice to know this too, okay? So this is great because like I said, anytime I do this, I can just quickly speed through and talk about the qualifiers, okay? So this, in the TLICs, I say these are my clinical qualifiers that turn non-operative case to surgical case and vice versa. If somebody has a TLIC score of 4, would you say that person is operative if they have an open fracture or non-operative? The nerve results, so you can actually see spinous process. This is pretty bad. Yeah. Or you can say that they're taking them to surgery. They do have a burst fracture, and they're going to put them in an interesting position. I think we should stabilize the spine before they do any big open fractures. Okay, overlying burns are troublesome. If they're within where you're going to operate on, you probably best not to add to the patient's issues with wound healing. if you can avoid to brace them. So all of these qualifiers sort of get applicable during TLIC scores where it's dealer's choice between 4, maybe a 5, depending on what MRI or what ligamentous complex and what the patient's exam is. But there are some qualifiers that, as you know, anytime we're 4 points, we're thinking about up versus non-up. If you have 5 points or more, we're thinking surgery, okay, with these qualifiers. But these are a little bit of examples that I'm going to go off. But just to talk about the reliability of the TLIC score, it's been validated, okay? There's a lot of people, I know Jens Chapman is not here today, so typically he'll be the big pushback and say, you never talked about the AO classification. We've improved it, it's better. And I said, well, but it's not a safe thing to talk to Chris Shaffrey about at 3 a.m. in the morning and tell him you've got a B2.4. So there you go. So I always say, look, it's validated. He gets it when I tell him this is the TLIC score. He can count from 1 to 10. It's easy for him to figure it out. So more than 90% of surgeons agreed with the treatment recommendations from the TLICs. And this is over a decade ago, and it's still tried and true. There are some critiques about the TLICs, which is it's surgeon bias. A group of surgeons got together and found out a way in which they can surgerize, quote unquote, everybody. But and there's a lack of evidence-based medicine. But it actually works, okay? It's easy to teach trainees. It's simple. It considers the most important decision points. And quite frankly, I love it. If somebody has an incomplete injury, you get a higher score because it just makes sense. Incomplete injury, higher score, get them to surgery soon, no debate versus complete. Maybe we can wait later, but not too late to get done. Yes?
Sir, for evaluating the posterior ligamentous complex, is every burst fracture getting an MRI scan at your institution, or do you do FlexX, or just take a look at the injury?
No, first you want to examine the patient. If there's a protrusion, there's gibbous, there's splaying on, in your back when they log roll them, you can assume that they have a PLC disruption. If you look at their CT, you look at the spinous process, if there's separation, more than likely. And also then you consider how painful they are. If, say, it looks like a stable burst, there's a lot of comminution or there's significant loss of the vertebral body, you want to consider this person will not do well. If this person is horrifically morbidly obese with a what you would say a stable burst, you then look at it and see how is the brace company ever going to put them in a brace? I mean, it's not going to work. So that's but for a PLC investigation, I always say, I don't need to always get them an MRI. Typically, if their pain is horrific, I'm actually interested in getting them an MRI because I want to make sure they don't have a hematoma, right? So, yes?
Also, what qualifies on the MRI radiographically to you as posterior ligamentous complex? If there's a little bit of stir,
True.
Opinions on it.
What opinions are troubling you? That would help.
Some people say, no, if there's a moderate amount of stir, that counts as posterior ligamentous complex disruptions. So there has to be visualized tear or something.
What do you think, Dr. Okonkwo?
Yeah, I think this is the dilemma.
This is the hardest part of it all, is the radiographic determination of posterior ligamentous complex. It's the factor with the worst inter-rater reliability. There probably isn't a good reason to just conclude a little bit of stir change in the posterior ligamentous complex is sufficient to make that determination. Alex Vaccaro, back in the old spine trauma study group days, actually set up a study where what we did was before surgery, we would look at the MRI and then rate the integrity of the PLC. And then once we got everything open, then you would re-rate it when you were staring at it with your own eyes and able to manipulate things. And what that showed is that it's a very hard correlation. So I think things like splaying of spinous processes, splaying of facet joints, these are much, much stronger indicators of loss of integrity of posterior ligamentous complex, but simply looking at a T2 or stir is harder.
It's a quick comment. I agree to everything. I was part of that trauma study group, and the thing we looked at, and he looked carefully, is a black stripe or a line on your T1 as well as your T2. Forget the high signal on your store image. That's extremely erroneous. You'll see it all the time, and that doesn't mean a lot. But if you have an MRI, I can show you. It's the one that's. It looks like the ligamentum flavum. It's a black line just posterior to the cord. And you watch carefully in your T1 or T2, you'll see it's broken. It's disrupted. And you follow the levels, a really good indicator is gone. And you follow that, and then of course you have splaying and CD facets and all that stuff, but look for it. Don't go by the stir. That's extremely confusing.
So I put this slide in because Jens Chapman insisted on it to know that the AO has mended their ways, and now in 2013, they came up with a neurological status and also key modifiers, very similar to the TLIX score, but yet still the TLIX score persisted. So this is what the flashcard for your pocket involve. I'm not sure I can still go through this at 3 a.m. with Dr. Shaffrey. I'll rather do that instead. It's so simpler. I have no conflict with the TLIX. I just know that it's easier when you're PGY2 to talk to somebody with a TLIX score. So treatment goals. We want to prevent further neurological deterioration. Okay, we want to promote neurological recovery, we want to stabilize the spine, and we want to restore anatomical alignment and facilitate early and active mobilization to prevent the sequela of somebody lying in a hospital bed. And of course, we want to minimize their pain and deformity. So, thoracolumbar injury options, compression fractures, brace or no brace for the majority. And this debate goes round and comes back again versus if it's a small, stable compression fracture and they have no pain whatsoever, there's no need for a brace versus you have to brace people to prevent kyphotic deformity, etc. And then there are those who will benefit from kyphoplasty, vertebroplasty, but that's also controversial. And then there's stable burst fractures where majority needs to be braced just in case there's underlying ligamentous laxicity that may come back and haunt you. And then also surgery if the disruption is quite impressive, but the patient seems to be stable with no spinal cord injury. And then there's unstable burst fractures, chance fractures, where they all need surgical intervention to be safe. Okay, flexion distraction injuries, fracture dislocation, similarly do need it. So a caveat for some of the pearls that I want to talk about is non-operative treatment does not always equal conservative treatment. Only a certain amount of immobilization can be tolerated. If you have somebody who is north of 300 pounds, they don't really do well. Do I really feel between the fascia that the brace is actually stabilizing them? It doesn't really work. I normally have a serious discussion as to compliance and also possibility of failure of this brace to circumferentially surround them in a meaningful fashion to hold everything in, particularly if you're teetering on an unstable fracture. Okay, of course you have to think about following them up in a clinic with frequent observations. Keep checking the any kyphotic changes, ligamentous distractions, anterior retrolisthesis even, particularly in the morbidly obese, particularly people with subtle neurological injury that may not want to have surgery, and also who have multi-system injuries. So then I go back to my qualifiers. There are some people that don't get an option at all. Let's see. Yeah, and those are those who have dish or ankylosing spondylitis or significant metabolic bone disease. I don't give them a whole lot of option with brace because it never works and it's actually very lethal. I'm not sure if anybody else disagrees in the faculty. Would you brace anybody, Robert? Okay. With dish, any time you've braced anybody with horrible ankylosing spondylitis with a long fracture at all?
In LA, nobody's wearing a brace.
Nobody's wearing brace.
Nobody. Forget it.
Okay.
Doesn't work.
Okay. All right. So I always want to defer to David as to when would you say somebody has a severe closed head injury and you're not ready to do the thoracolumbar fracture? How do you work through that algorithm?
Yeah, it's boils down to understanding whether the
If you are actively combating someone's intracranial pressures, that's a bad idea. That's the wrong time. But someone who is in a physiologic sweet spot with their intracranial monitoring and who is hemodynamically stable, if you don't get this out of the way, then you will find a very long delay in actually getting it taken care of, because then the downstream things will happen. They turn febrile, then they've got an unexplained white count, then they get the pneumonia, and if one thing has been demonstrated, it is that we've struggled to prove that early decompressive surgery improves neurologic outcomes, but it is very clear that the faster you take care of these unstable spine fractures, the better it is for the patients when it comes to risk for prolonged mechanical ventilation, ICU length of stay, and how quickly you can transition someone into rehabilitation. And the thing that I think bites people is they try to wait a couple days, and that's all it takes, is waiting 2 days before the other problems then subvert your goals. 2 days turns into 2 weeks.
And though, just moving on, thanks, David. Though moving on, if you look at surgery for thoracolumbar burst fractures, they always compare anterior versus posterior stabilization. I always have this caveat that yes, they may have equivalent neurological outcomes, but I tend to have this caveat that short segments don't do well with older patients. It may seem contraindicated, but if they have poor bone quality, it's not. I don't think it's a good idea to try to do a lateral stabilization technique and just stabilize them there. I think it'll be prone to failure. You have to literally get more anchor points before your whole construct starts backing out on you. Okay, so again, more instability or deformity, poor bone quality. There's failure with short segment posterior instrumentation, so you need more points of fixation, and sometimes you may even require anterior column support. And again, posterior treatment of TL injuries is a must for people with AS, DISH, rheumatoid, osteoporosis, and those who are severely malnourished. They don't do well with healing. Okay, this is a simple case that sometimes I gloss over. Let's see, we're going to move on. This person has no spinal cord edema, 40% canal compromise. They have incomplete neurological deficit, T12 burst fracture. He warrants a decompression, not bed rest, not a TLS. So this is what happened to him, and this is a short segment, which for a very healthy person. This was before expandable cages were in vogue, and this was before Rod knew what to do with a lateral access, and that's him with his whole hands in there, contrary to what he says. He used to have huge incisions with Chris Shaffrey, and that's Chris Shaffrey staring and wondering why I'm taking a picture in his OR. So. And this is Rod on his last day as chief resident. It's wanted me to take a picture of him, but these days in Pittsburgh, they're doing it a little fancier. If you're young enough and you do activities that bring you to surgery, you might get an expandable cage and a small incision, a la people who like to windsurf. But typically, it's a simple procedure, quote unquote, with minimal blood loss. In the optimal patient, you can get away with a short construct, etc. So there is always the discussion. I don't know what year it is, but there's always this coming back to, should we brace people? Is there a level of evidence for bracing anybody who has a stable burst fracture? And the level of evidence continues to say operative management of traumatic thoracolumbar burst fractures. The decision as to whether to brace somebody or not, there's equal level of evidence that they do well, but there's also lower complication rates with that conservative management. But if there's a neurological deficit, they're not very clear. And I say, why is there no clarity in this? If there's a neurological deficit, you should offer them decompression and stabilization. So the instrumentation techniques and technical considerations in thoracolumbar fractures. Basically, the bottom line is you want to reduce your soft tissue, limit your dissection when you're doing percutaneous. A lot of places are switching. How many people have completely switched to stabilizing the TL junction with percutaneous instrumentation? Okay. David, you're saying no. What do you think?
Most of this is damage control.
Right.
So the person who's neurologically intact, I'm willing to entertain this, and I think there's a lot of upside to the percutaneous fixation of the person who's neurologically intact. But in my hands, this is a longer operation, and an open procedure. If it's a T12 burst fracture and I can get screws at the index level, which means I can then do a short construct, T11 to L1, I can do that operation open in an hour, skin to skin. And I can do a quick laminectomy, which is usually halfway done already by the fracture pattern. And then every now and then you discover a compressive epidural hematoma that you might have otherwise missed. I think the person who's neurologically intact, it's just like something we didn't talk about because of time limitations the last time. If you have a facet fracture dislocation and you're trying to decide whether to get an MRI or you're trying to decide whether to do closed reduction, the person who's neurologically intact, the only thing you can do is hurt that person. Right? So I'm much more likely to get an MRI in the person who's neurologically intact. The person who has a neurologic deficit, just fix it. And it's the same thing here. The person who's neurologically compromised, just fix it. And I can do that fast. The person who's neurologically intact, get your MRI mentally,
Got it.
go through whatever self-gratifying exercises you want to do,
Yeah.
and then come up with some overly complex plan.
Okay. So I'm not going to debate the disadvantages of the percutaneous fixation because it's on the rise. Yes, Nuj.
Just to kind of reference that comment. A lot of the time, the comment is made that with percutaneous, you can easily distract and achieve ligament ataxis, and that will help bring back, retropulse fragments from back into the canal and so on. In my experience, no matter how hard I've tried, and I have heard this from other people as well, it is inferior for that purpose. I cannot satisfactorily reduce a retropulse fragment through ligament ataxis, no matter how careful, minimally invasive, but forceful in my distraction I am. And I would challenge anybody to claim that they could achieve the same through an MIS approach.
No. I think David's point, it matters neuro intact or not. If the patient's neuro intact, MRI, I'm not decompressing. I don't see any rhyme or reason to decompress irrespective of a retropulse fragment. And I tell the patient right up front, we're not touching this. You're fine, it's going to be okay. Percutaneous fix and done, you're over. If he's got a neuro deficit, he's getting decompressed. Now, whether you want to do a posterior lamb or you want to do a corpectomy, choose what you want. But he's getting decompressed, but still with POC instrumentation. I'll still go up and down, doesn't matter. You can do open, that's fine. But I think it matters if the neuro intact or not. And you don't have to reduce that burst fracture if he's neuro intact. It doesn't matter, leave it there. That's what I wanted to say. It doesn't matter. Don't struggle reducing that damn thing. If he's completely neuro intact, it remodels. It doesn't matter.
Yes.
We have a new term, ligamental augmentation. How are you going to do that with MIS?
Ligamentous augmentation. Explain that.
So we just talked about that.
Yes.
About the construction, you put some rope there.
So that's deformity versus trauma. So we have this thing that fixes the trauma and don't try to add your deformity to it.
No,
You're in there for trauma, do the trauma.
Ignore the degenerative.
Right.
This happens all the time. Someone has an L1 burst fracture, but they also have an incidentally discovered L4-5 spondy. Ignore the degenerative and treat the trauma.
Are you talking of ligament injury in the back?
Yes, but they can get the PJT as well.
All right, then you got to fuse that level. We showed this. Mark and I wrote this paper, and we talked about it in NAS. If you got a true bone chance fracture, you don't need a fusion. You can internally brace it, poke it, it'll heal. The brace heals it. But you got a ligamentous injury in the back, you should fuse that level. Ligamentous injuries will fail over time. There's a really nice paper on adolescent case story where they percutaneous instrumented it, removed this thing at 8 or 9 months, and she fell right apart. But ligaments don't heal in the back, so you should fuse that. There's a ligament injury in the back for that level. So let's say you do a T12, T11 to L1. You're just doing the T11, 12. You don't have to do 12-1. And then take the hardware out at 1 year, but fuse the ligamentous injury level. That needs to be fused.
So it's also important if there's an upside to the AO classification is that it really makes you think about the vector of force that produced the injury. Was it axial loading? Was it a rotational injury, which are the C's, or was it a flexion distraction injury? Okay, and the C's, the rotational injuries, are very dangerous injuries. If you have a true AOC, and what people will do is they will misinterpret a burst fracture as they will misinterpret a rotational injury as a burst fracture. And the person who actually has an AOC injury that's a rotational injury, you're getting ligamentous disruption above the level that looks bony injured. And then if you only treat the bony injury, then you're at risk for proximal junctional failure. But genuine proximal junctional failure in trauma is actually very rare. If you're missing an injury and now you're doing a construct that ends below the level of the ligamentous calamity, that's a problem. But if you're incorporating the ligamentously disrupted level into your construct, then the next level above rarely has a problem.
Is that clear?
Here, make one more comment. There seems to be something that PERC instrumentation means no fusion. That's not true at all. PERC instrumentation is just a way of instrumenting. You decide then if you want to fuse or not. You can still fuse. All you do is instrumented PERCs. You don't mix the two together. It's only a way of, that's one comment I had. Second is, AOC's got to be fused. AOC is not getting PERC instrumentation. Even if you PERC it, you're fusing it. That's extremely unstable. And third, the only other classification I find very useful is Gaines' load sharing classifications. Extremely useful to know how comminuted the vertebral body is. It's a really good indicator. If you got something like 4, 5, 6 severely comminuted, that's going to fail. You don't do short segment. You look at it carefully. It's the only other thing I'd add to TLIX. It sort of adds in. If you look at the load sharing, how comminuted the vertebral body is on CT scan. You got a sagittal pincer fracture split completely. We talked about yesterday. Comminuted. You're not doing short segment on that one. That's going to fail.
Correct. Yeah. The Gaines comminution index is rarely talked about, but I don't think you need to know whether someone has a Gain 6 or a Gain 9. I mean, that's ridiculous. To actually calculate the Gaines comminution index is ridiculous. What is helpful, though, is to understand the principle, which is if you look up the Gaines comminution index, it's very simple. It's basically how many tiny little fragments has the bone been fractured into. And if you're looking at a CAT scan of something where that bone has been broken into 20 pieces, you really need to think that you either need a longer construct or you need anterior column support. And so Neil raises a great point that the Gaines comminution index, which rarely gets talked about, it's rarely taught, but if you just have situational awareness of the principles of what the Gaines comminution index is trying to tell you, then you can think to yourself, you know what, this is the moment that I have to say, anterior column support is appropriate so I don't get the failure. And what looks like a proximal junctional kyphosis or looks like a post-traumatic kyphotic deformity is in fact the failure to understand the need for anterior column support leading to failure. Mike, did you have something to add to that?
No, I mean, I think the only thing I would add is the Gaines classification or the Gaines index. What happened was at that time they were using the Cottrell-Dubosset pedicle screw system, which was one of the only few that they had. And him and Rob McLean looked back on all of their fractures and found out which ones all failed. And they failed when they had the high comminution. So I think that's the key that we really learned from that is what did this classification mean? And at the time, all of these were failing because they failed at the screws, they failed at the rods, because nobody really understood how to apply these short segment fixations. And I think we learned a lot from that, but then we've advanced.
How about you, Bob?
I wanted to amplify on what Michael just said. I think a lot of those early failures were due to technique and due to the implants. So the implant designs are now better, and the technique that was employed was this strong distraction, which really is not necessary. Going back to what Neil was saying, I mean, we don't need to decompress. We don't really need to restore height here. In a neurologically intact patient, if you just stabilize them where they're at, correct them out of kyphosis. If they have kyphosis, you're done, right? And I don't know that I do one above and one below often, but if you can get the middle pedicle, I think as David was saying earlier too,
The
then you can't
index
stop.
fracture, put in pedicle screws in the, do you think
got a
that
nice stable
helps
construct.
with pain control also versus?
Yeah, I think so. I mean, I think there's fracture-related pain, right, that you stop once you stabilize the fracture. So.
Okay.
The only other thing I want to add, I guess it's always when you get old, is you talked about the Mogral classification, which was the 1994. You talked about the initial AO classification. Well, I did a fellowship in Mogral, and I was there when we counted all the cases in 1989 and 1990 with Rick Sasso.
Thank you.
But the point was how we did those. Most of those fractures were treated with an external fixator. So I put about 100 external fixators on the spine at that time because that's how we were treating fractures. And then it was a guy named Walter Dick that internalized an external fixator for the spine to be able to put that in without using an external fixator. So it went from an external fixator, which is how we treated the spine, and my job was to take that electric saw or electric knife and cut a big hole in the bed so that when we had this external fixator on the patient, we would flip them over and they had a place for the external fixator to go. And then we saw which ones failed with the external fixator. Then in Basel, Switzerland, a guy named Walter Dick decided I can take this external fixator and put it in the spine so everything was internal. And that was the fixator intern. And then from there, we started doing short segment fixation and the Gaines classification and all these things. So a lot of these classifications were with systems that we never even use today. And I know if you say people in Los Angeles don't want to walk around with a brace, for a while I tried putting external fixators on when I moved to Denver in 1990, and nobody wanted to walk around with a sign that said Mike Jansen is my doctor with all these things sticking out of their back. But I did 100 of them during my fellowship. So it was very interesting how whatever you do during your fellowship now in 10 or 15 years, it may be relatively obsolete.
And we thought the fellowship was hard, I guess. All right. So, in conclusion, there are people who've had a harder fellowship and residency than you, but really, you need a uniform language to discuss mechanism of injury. It makes it easier for all care participants. You have to have a plan and stick to it, but you also have to have a backup. And if you have those in your armamentarium, you're not savoring the case. You're not sort of staring at fractures and nerve roots and trying to figure out what to do because you've already had a plan in your head and you have a backup. And these days, you have to nurture your trauma service because they make things happen after you've fixated, fused, and stabilized the patient. Okay? All right. Thank you.